Assalamualaikum and hi. Welcome to my short video on critical care in emergency department. Is it time? My name is Zulhelmi bin Muhammad Zain from Hospital Putrajaya. So before I answer to the question, let me just give brief introduction on my topic. Whenever patient arrives at our emergency department, we usually start with initial resuscitation, which involve early diagnosis and stabilization for the first 1 hour. Then we'll book the ICU bed. However, overcrowding in most of ICU beds in the government hospital make this sometimes impossible. This is because our emergency department are not designed or staffed to provide good care beyond the initial period. Therefore, patient will remain in the department receiving suboptimum or substandard care. Our aim is that patients should deserve to receive the same evidence-based intensive care regardless of location, whether in ICU or the emergency department. This is about numbers of patients admitted from different locations to the ICU from year 2004-2013. As we can see, in the emergency department, the numbers of patients admitted to ICU has increased quite significantly compared to other locations. Next, this table is about intensive care referrals and refusal of admission. About 5.6% in HPJ were denied admission to the ICU. The main reason by the Malaysian Registry of Intensive Care is due to unavailability of ICU bed. In Serdang in HKL, the numbers are even bigger. In Hospital Ipoh, the numbers is the highest. My point here is that whenever patients were denied admission to the ICU, patients will be stranded at our emergency department. So I think it's time for us to prepare ourselves to start and to continue the care of critically ill patients. So is it time? My answer is definitely yes. I've got 6 points here to support my stand. Point number 1, to provide optimum critical care. By providing critical care in the emergency department, patient will not only do better, but we can actually decrease the length of stay in the hospital and decrease the healthcare resource consumption. Point number 2, increasing number of critical cases. Whether we like it or not, this is the fact that we have to face. So it's time for us to prepare ourselves. But of course, great advancement require great investment. Point number 3, public anticipation. Whenever patients arrive at our emergency department, I'm talking about critically ill patients, after we start the initial treatment, the public, the family members, the relative will assume that we continue the care of the patients, regardless of the overcrowding of ICU or not. Point number 4, availability of therapeutic and monitoring technology. Once the fiber optic bronchoscope, the ETCO2, the sepsis monitoring were once considered as ICU expertise, but nowadays most of them were being done routinely in the emergency department. Point number 5, overcrowding of ICU. Because of this, patient will be stranded in our emergency department. I've shown this in the earlier slide where the percentage of refusal of admissions are increasing year by year. So again, we have to prepare ourselves to provide standard and optimum care to the critically ill patients. And last but not least, point number 6, impact the progression of organ failure. In one of the studies by Nguyen, it says that there is a golden hour and silver day in the continuum of care in the critically ill patients, which suggests that the reversibility of disease and mortality and morbidity may be greatest in the initial hours of presentation. So, what next? If yes, we have to proceed with all these points. Policymakers, we have to involve the government, the Kementerian Kesihatan, Kementerian Pengajian Tinggi, the Jabatan Kesihatan Negeri, and other respective agencies. Point number 2, training. Trainings is very important. And point number 3, assets and locations. Point number 4, human resource, which involve the staffing, the KPI, the training as well. And last but not least, but the problem of all is the budget. So these are all my references. So with that, I thank you. Assalamualaikum.